Greetings everyone once again. Welcome to the 130th session of the online Optom learning series. And for today's session, we have with us an optometrist, Mr. Cian Gildea. He is a graduate of the Technological University of Dublin, where he obtained his degree in optometry. And during his studies, he also had an opportunity to complete his training at the University of Houston School of Optometry. Currently, he is actually practicing as a clinical-oriented optometrist, if I may put it that way, at the Wellington Eye Clinic in Dublin, Ireland, where he specializes in contact lens fittings in irregular cornea, also in myopia management and in dry eye management as well. And the Wellington Eye Clinic, where he works with a couple of optometry colleagues as well, is a specialized center for anterior segment as well as refractive surgeries. And very recently, he's also passed his VIVIORs and he has gotten his certification from the BCLA, which is the British Contact Lens Association, in terms of the principles of myopia management. So very recently, he has taken up this challenge to further his education, and it's a very prestigious certification award whereby it allows us, to do myopia management very efficiently. And I think today is going to talk to us about what changes COVID-19 brought into practice and how did Wellington Eye Clinic experience. He's going to share that with us on how did he come about, changing things and what happened and how we can incorporate some of these ideas in our practice. So welcome, sir, onto our platform. And let me just leave the screen time to you.
Yeah, thanks very much, Rudden, and thanks for inviting me to speak with you all. It's a pleasure, and I really appreciate you giving up your Sunday evening to listen to the experiences that we've gone through here in Ireland. And I'd like to start a conversation as well, really, about what your responses have been to the COVID-19 pandemic and how you've adapted practices. So I'd be really interested to hear your experiences as well. So I'd love if you use the chat box and then afterwards for questions. It would be absolutely great. And just quickly as well, I just want to say to Rudden, congratulations on being appointed to the board of directors for the International Association of Contact Lens Educators. And that's a fantastic achievement, and I'm sure a role that you'll really prosper in. So without further ado, I will start the talk. So here's a brief outline of the clinic in Ireland. So it's an ophthalmology-led clinic. It was established in 1980, so it's been around for a number of years. And 90% of the time, we're dedicated to cataract, refractive surgery, and keratoconus. So we'd have roughly 10,000 patient visits annually, and we do over 2,000 procedures per year. Those procedures, again, being LASIK, clear lens refraction, or clear lens exchange. We do implantable Collamer lenses, and then cross-linking for keratoconus. So again, Rudden has introduced me already, but here's a brief rundown. So I have a special interest in irregular cornea lens fitting, myopia management, dry eye management, and obviously refractive surgery. Here's a brief format of the talk. So I'm going to talk about our experiences so far with regards to COVID-19 and how we've had to adapt our practice. And we've heard reports from elsewhere in the world of the huge changes that people have had to make to their practice to adapt to these new circumstances. We'll talk about the impact of lockdowns and how more people are working from home now. Consequently, because they're working from home, the increased time spent on screens and how that's actually differed from people being in an office-based environment to actually being at home on a screen. So people are spending a lot more time. They're having their lunch probably, whereas before they would have gotten up and gone talk to colleagues, etc. But now they're eating at their desk, Zoom meetings all day, and so a huge increase in the amount of time people are spending on screens. And then how we've employed technology to help us with to help us through the pandemic, essentially. So what I will do, here's two proverbs, I suppose, are quotes that I think are quite apt. The first one: the wise adapt themselves to circumstances as water molds itself to the pitcher. And then Charles Darwin: it's not the strongest of the species that survives, nor the most intelligent that survives. It is the one that is the most adaptable to change, and change being the order of the day. So I'll actually ask Macrudden if you could launch the first poll for me there, and whether you feel the pandemic has increased the amount of dry eye patients that you've seen in clinic.
Okay, I certainly feel that there is an increase. I mean, that's my personal experience. I feel that people are coming in with, and I think symptomatic dry eye is more of an increase. People come and people say that I feel dry, you know.
Yeah, and I 100% agree with you there, Macrudden. It's been, it really has been astounding the amount of patients presenting now with dryness. So, and you're sharing the results there now. So an astounding yes. So people have been noticing it, and I suppose it's interesting. It's not based on, say, location of it's not an Irish phenomenon, but you guys have been noticing it as well. And the second one, Paul, I'll get you to launch as well, Macrudden, if you don't mind, is what do you think is driving this this increase in dryness? So is it mask wearing, increased screen time, combination of factors, or you just don't know?
Sure. So yeah, I think there are various factors, I think, but then what probably as you mentioned in the beginning, people are now spending a lot of time on digital devices, so that could be one of the potential factors, I think.
I think from a patient reported point of view, they are coming in with dryness, saying that but I think patients are becoming more aware, and they're ascribing it to increased screen time. They definitely report, or they're definitely more aware that they are spending more time on screens over the last year or so, 15 months. And I think from our experience, they're definitely saying that it's the screen time that they feel is driving it.
That's right. Okay, so let me just end this. I think we have gotten maximum responses. And
both combination, and then increased screen time as well.
That's right.
Yeah. Okay, so we'll go back to the talk here now. So yeah, very interesting responses. So here's a brief outline of what COVID, or how our COVID journey here in Ireland. So the first lockdown was announced at 9 p.m. on the 27th of March 2020. It lasted for 7 weeks until the 18th of May, and everywhere was shut down for that. Lockdown, including our clinic. Now, we were allowed to see patients on an emergency basis. We weren't allowed to see routine patients. But after the 18th of May, when we reopened, we were allowed to see patients on a routine basis. And you can see over there on the right-hand side of your screens a chart of the cases from last March. And we're just recently we're beginning to come out of our third lockdown and our third wave. And you can see the third wave really a large spike in cases. So what did we do during that initial lockdown when we weren't allowed to see routine patients? We had Well, again, this is this is something that I'm sure you're all very aware of, closed due to COVID. But the sentiment around COVID, here's a word chart on how patients were feeling, what they were reporting to us, the general public as well, and it was basically a big feeling of uncertainty. There was nobody really knew what to do. It was something that we were adapting with on a day-to-day basis. But we were lucky enough to start some remote triaging. So we all had access, all the clinicians had access to the patient files remotely via our digital patient management system. But we were using something called Advanced Ophthalmic Systems. So this is a patient and clinician mobile imaging app, as well as software that you can use in office. And it's objective grading of the anterior segment. So if a patient says, listen, I have a red eye, I don't know what's going on, they can physically take a picture of their eye themselves on their iPhone or smartphone, and that's sent to the clinician, and then we run it through the software, and that can grade redness, etc. So you were essentially being a virtual optometrist and then triaging patients that needed to be seen. If you thought it was an emergency, if it was say a scleritis, or if it was just, say, for instance, a subconjunctival hemorrhage. But it's great. It was great for patient engagement. They felt like the advent of telemedicine is absolutely huge now as well. And it's again, the patients felt there was that wow factor to it. There was how the advances in technology were absolutely great. It's really good for contact lens fitting as well. So say if you're fitting a scleral lens, it's great for tracking, say, impingement or blanching or anything like that. And here's a couple of photos of the software. So we made all the necessary changes led by government guidelines in order to reopen. And here's a quick overview of what we had to do based on the government guidelines. And I appreciate it's going to change from country to country. But in the Irish context, we had to reconfigure the waiting area for social distancing, perspex barriers, floor stickers. The patients had to pre-book, and we obviously had to employ all of our PPE instruction videos on our websites for the patients to watch, to basically understand the new processes that we had employed. So here's a couple of photos of our clinic. So that's the front entrance to our clinic there. Sanitizing station, and then the front desk with the new perspex put up for everybody's safety. There's a new waiting room with, again, perspex in between and 2 meters distancing between the chairs. That's outside the consulting offices or the consulting rooms. And here are some more photos then. All the devices then obviously had to put up perspex screens. If you think back to the very start of the pandemic, it was a Chinese ophthalmologist that actually realized that there was something going on with a new virus, and optometrists were adversely affected in terms of contracting COVID-19 because of the time we spend very, very close to patients. Again, here we have a picture of the reception staff. That's our laser suite. Again, perspex barriers between the optometrist who would operate the laser and then the surgeon who would be performing the surgery, and that's our canteen. So huge amount of changes that we wouldn't have expected, and we've had to make these changes, and COVID-19 being the catalyst for it. So before when a patient would come in to see us, they would spend about 2.5 to 3 hours in the clinic. They come in, they fill out their form, tests and scans, etc. And then they'd see the optometrist, and then they go and see the ophthalmologist. So we completely rehauled how we engage with patients. First of all, we realized that a lot of the visit you can actually do remotely, so that when they come to the clinic, you're very focused on the clinical side of things. So first of all, they're all sent any prospective patient is sent a medical history form, which they fill online. And once they fill their medical history form out, they are offered 3 appointment times. So we send out a text message with 3 appointment times for a virtual consultation. And the virtual consultation is carried out with a nurse or technician. So this is an example of the text messages that they receive. They have a choice of 3 times, 3 dates, 3 times. If they don't like any of those dates, or if they don't suit, they reply that they don't suit, and then they're sent out another 3 options to book an appointment. We use a platform called Doxy to do a virtual patient screening essentially, and we do a structured conversation with something called form stack. So the nurse or technician runs through a list of questions basically around lifestyle, what they want from the appointment, etc. So I'll just run through some of those now just to give you an example of what it's like. But form stack is very, very good. You can build whatever type of appointment or case scenario that you would like. So here we have the current use of glasses or contact lenses, confirming their age, if they know they're short-sighted, long-sighted, if they have astigmatism. We also include, because of what we were seeing in terms of dry eye patients, we included an ocular surface self-assessment. And we can see here, do they have watery eyes, gritty eyes, blurred vision, anything like that. And we go on to dive a little bit deeper and ask them about how much time they spend on screens, because we really feel that screens are a huge driver in relation to the amount of dryness that we're seeing at the moment. Then we would advise them to start a dryness regime. Most of the patients are coming for a refractive surgery, and we know how important the tear film, the ocular surface is in making them potential candidates for refractive surgery, but also just in general for patients' vision and the stability and the quality of the vision, all dependent on the person's tear film and having a good tear film. So we send them this, we email them this overview of dryness that we've made, and we know that probably about 80% of patients that we see in our clinic, it's an evaporative dry eye driven by meibomian gland dysfunction, as opposed to, say, an aqueous deficient dry eye. Now, this is bringing me on to the mask associated dry eye. Now, I'm not sure if mask wearing would have been a big part of culture where you guys are not, but in Ireland we wouldn't have had a culture of mask wearing at all. So it was a completely new phenomenon for us, having to wear masks during the pandemic, and the associations of wearing a mask has brought on a lot of dryness. And you can see that the University of Waterloo in Canada coined the term the mask associated dry eye. And again, the cause of it, wearing a mask that doesn't fit correctly, especially over the bridge of the nose. And basically air, when you're breathing out, gets redirected by the mask upwards, and that causes an increase in the amount of evaporation of the tears. And like Fakrudin had mentioned at the start, people coming in with symptomatic dry eye, they're very aware of their eyes, they're very aware of that gritty, scratchy sensation. Now, Fakrudin, I'll actually ask you to run another poll for me there. So in terms of the dry eye management, what do you currently offer? So we have advice only and refer, lubrication drops, hot compress, medication, or specialized treatments, for instance, the IPL or LipiFlow.
Yeah, it's been seen that lubrication eye drops is kind of the majority favorite,
Yeah.
which most people are prescribing. Yeah.
And I suppose from our point of view, the most important kind of emphasis that we'll put on is that they use a preservative-free lubrication drop. We know that a lot of the preservatives are toxic to the ocular surface, so look at things like benzalkonium chloride. So when you are offering a lubrication drop, hopefully it's preservative-free. The other thing that I've mentioned when it comes to lubricating eye drops is that if try to target them towards the type of dryness that you're seeing. So if it is an evaporative dry eye, make sure that you're offering something that has a lipid support in it versus say something with say a mixed or a aqueous deficient dry eye. So no, that's very interesting. So lubrication drops, and for us as well, hot compress is the cornerstone of any evaporative dry eye treatment. We really stress that the hot compress is very, very important. Explaining to patients that dryness isn't, it's chronic in nature. There's no silver bullet that's going to completely rid you of your symptoms and you'll ride off happily into the sunset. It's something that has to be constantly managed. And with people spending more time on screens and reduced blink rate, so your average blink rate is between 15, 25 times per minute, it's been shown that the blink rate reduces by about 50% when you're on the screen, and that drives evaporation. So here's a little experiment that we did in clinic on mask-associated dry eye. So we have a device called the HD analyzer, and that measures ocular surface scatter. So it shows what the tear film, what impact the tear film has on the image seen by the patient. So you can see on the left up here, that's what the patient should be seeing. And then this is a composite of what the patient is actually seeing because of the scatter produced by a poor tear film. So this patient was actually wearing a mask when we did this scan, and you can see the vision breakup time of a second. Then what we did was we got the patient to take the mask off and sit in the clinic for 10-15 minutes. We got them to blink a lot, blink correctly. We didn't put in any preservatives or any artificial tears or anything like that. And then we repeated the scan 15 minutes later, and you'll be astounded by the results. So you can see the ocular surface scatter is reduced from 3.9 to 0.3. The images are essentially the same, and vision breakup time is absolutely normal. So that is a huge impact of what the masks can have on the ocular surface and symptomatic dry eye. I just want to share with you as well the impact of the tear film can have on on different scans. And very important when it comes to, say, you're referring a patient for cataract surgery, and if they have a poor tear film, they're more than likely going to end up with a poor result. And they'll blame the surgery on the poor result, and not necessarily the fact that they had a poor tear film going into it. And again, that's why it's so important to really emphasize that if you notice any degree of dryness, meibomian gland dysfunction, that you treat it accordingly first to best serve the patient to improve outcomes. So this is a patient that we saw came in for cataract surgery, and we did the biograph to measure the eye. And you can see in the right eye there, it's measuring almost 5.25 diopters of SIL, and the left eye 2.75 diopters of SIL. So this patient 100% would have been having a toric IOL, but we knew that the patient was dry, had a poor ocular surface. So we advised compress, omega-3 supplements, lubrication eye drops, and gels. And we sent the patient away for 2 months. They came back in June, and look at the difference there now. So went from 5.25 diopters of SIL down to 1 diopter of SIL in the right eye, and from 2.75 to 1. So that really highlights the impact that a poor ocular surface can have on a crucial piece of information such as biometry. So actively managing dry eye patients are patients that don't necessarily know that they're dry, but if you see they have a poor ocular surface, the importance of managing it and treating it. So again, here's a quick synopsis of the tear quality. It's not to be underestimated. It's the largest change in refractive index is going from the atmosphere to the tears. Normal tear volume is 7 microliters, and it's 7 micrometers thick. The lipid layer, hugely impacted in today's modern lifestyle with screens. It's only 42 nanometers thick, and that's the importance of keeping a good lipid layer and the impact that will have on dryness. If you're recommending patients go for refractive surgery or for cataract surgery, you really do have a very, very important role to play in managing that patient and getting them to a good level that will help them support a successful surgical outcome. And for yourself, if you're doing, say, ortho K in terms of myopia management, or even for, say, contact lens fitting, they have a poor ocular surface, it'll impact your scans as well. So moving on to, I suppose, maybe the second thing that we have noticed during the pandemic, and that has been the amount of time that people are spending on screens. We know that people are now beginning to work from home, and we need to do something to address what's going on at home now that they're not in offices, and how people are spending time on screens. So there's a huge disconnect in a patient presenting for their exam. We would put an awful lot of emphasis on, okay, is the eye healthy? What are their vision problems? But the patient wants to know, are they more interested in, what kind of outcomes that they can receive? What are their options? Obviously, they want to know if they have a healthy eye or not, but they want to know, given their particular set of circumstances, what can they do about their vision? So us as practitioners, we do an eye health exam. We measure vision. We look at the posterior segment, anterior segment, see if there's any issues there. And there's several hundred millions per year is invested into generic static objective data. Okay, and that is very important. But what are we doing about visual behavior? All we have at the moment is we're carrying out subjective questionnaires based on the patient saying, well, I spend this amount of time doing this, or I spend X on my computer, I spend the rest of my time out cycling, or whatever it is. But there's no objective data on what the patient is actually doing. And there's a huge mismatch between those two things. And what we'll notice as well is that because of that, there's about 10% of customers return seeking for an improvement, longer adaptation times to, say, progressive varifocal lenses. The focus is on eye health as opposed to comprehensive health solutions. And this is huge. 55% of customers are patients not fully satisfied with their optical solution. And it's important to remind yourself and to reflect on this. So uninterrupted patients only took a median of 6 seconds to describe their vision concerns. And us as practitioners, the clinician interrupted the patient after a median of only 11 seconds. And then just a quick stat about a sixth of US ophthalmologists would experience a lawsuit because of informed consent issues. So we've been employing the use of a device called VIVIOR, and it's essentially a Fitbit for your visual needs, and it gathers objective data. So it's a cloud-based solution combined with a wearable device that you mount onto your spectacles. And this objective data can be used for ergonomics at the workstation, can measure how much time people spend doing different things. We've been using it very successfully for cataract patients or for refractive lens surgery patients. And I'll talk to you a little bit more about that in a second. But it uses laser technology, can measure a whole host of things. So what distances you're spending or you're working at, the ambient light, the head, neck position. And the great thing about it as well, in terms of protecting privacy, there's no cameras involved. So here's a brief overview of how it works. You wear the device for about 5 to 7 days. Like I said, it clips onto your glasses, and you get a whole host of objective data. And once you get your objective data, it prints out or gives you a personalized defocus curve. So how much time you're spending at each distance. And then that report can be shared with us, the clinician, in terms of driving which say varifocal lens would be the best option. Would monovision contact lenses be a good option? Would a progressive contact lens be a good option? The report can be sent to someone specializing in workplace ergonomics as well. And there's now a huge emphasis on telehealth and workplace education. So it ticks all the boxes there. So at the moment, all we've been doing is a subjective assessment, or up until this point has been a subjective assessment. So you can do an in-depth interview and questionnaires, but it's all patient reported as opposed to objective data. And we know the importance of objective data. I might think that I only spend 2 hours a day on my screen, but with the objective data, there's no arguing with it. Taking the subjectivity out of it makes a huge difference. So these are some of the things, again, that it measures: so working distance, ambient lighting, head position. And here are some of the printouts, or the reports that it will include. So up at the top, that's a defocus curve. It shows you how much time you're spending at each distance. In the middle, that's another representation. At the top, it's showing good light, then kind of twilight, and then in dark conditions, and the amount of time near, intermediate, and far. And then the final one is your head position. So again, if you look here, you can see that the defocus curve, how much time they're spending at each distance. So you would be surprised at how much, how widely these vary from patient to patient. You can look here, it knows whether you're being sedentary or not, whether you're just sitting at your desk, how many times, like how much you've been or how active you've been during the day, whether you're looking left, right, up, down. It'll know whether you're down looking at your phone, and it will also look at flexion as well, whether you're looking left, right, how much time you're being exposed to blue light, so how much time you're spending on a digital screen. And we know that that has a huge impact in terms of myopia and myopia progression. The ambient light, are we outside in good lighting conditions, i.e. outdoors, or if we're inside on screens. So here's an example of 6 different defocus curves. And what we've been doing in our clinic, especially for cataract patients, is our refractive surgery patients. When it comes to, say, IOL procedures, you can physically match a person's defocus curve with the design of IOL that you're inserting, whether it's a trifocal, whether you're going to go with monovision, whether you go with some mini monovision, but it does the exact same thing for progressive lenses, and so you're essentially tailoring to the individual patient's needs and how you can adapt. You can see that the one design of varifocal isn't going to suit all of these patients by a long shot, and that's why it's important. And people are becoming more aware as well of tailored solutions to their particular set of issues. It works off something called LiDAR. So there's no cameras involved at all. It uses light and basically how long it takes for the light to reach a point and then return then to the sensor. Another way that we've been employing the VIVIOR device to huge success is actually with our myopia management patients, to get a good idea of how much time they're spending outside, how much time they're spending on their digital devices, and what sort of activities that they're doing. And so we'll have the patients wear them for a week, and it's a really, really good engagement tool for the parents and for the kids themselves to really get a deep dive and an in-depth view of what they're doing on a day-to-day basis. So again, it's just showing no cameras. So it really is bringing all aspects involved: personalized vision correction, performance. They might spend their working week with a different varifocal or different design of varifocal compared to what they would spend at the weekends when they're doing their leisure activities. And again, computer vision syndrome, this is a huge thing. And the issues with, say, neck, shoulders, general ergonomics and health and safety around that point of view. So it really does a whole host of functions to try and improve patient outcomes. So I'd like, Fakhruddin, if you could launch the next poll then. So have you noticed an increase in the progression of myopic patients during the pandemic?
All right, I think it's all mostly skewed to yes, but I feel that a couple of my patients, especially the young kids, a couple of them, I saw their myopia has a bit progressed as compared to what they were in the previous years. I mean, that's my personal opinion.
Yeah, we've definitely noticed an increase in the rate or the rate of progression among our myopic patients, and it is down to the lockdown. So all the kids have had to do remote schooling, so they have spent their day on a tablet, on a computer screen. So that's a resounding yes
Yeah.
there. And it's something that I would definitely agree with in our experience anyway, as well, as that the amount of the increased progression. And we've looked at some studies on it as well. We know that there's an association between screen time, shorter working distances, spending time indoors with the rate of progression of myopia. And we know that visual behavior has a huge role to play. Now, genetics in myopia, in myopic progression, definitely an association there, but also the visual environment and time spent outdoors and in good UV light. So here's some studies looking at myopia in school children after confinement. So finally, another thing that we've been using to I suppose help patients realize how much time that they're spending on screens are tablet, smart devices. There's lots of apps out there to actually track and manage what you've been how much time you've been spending on devices. So we use two apps. One of them is called the Space app, and then the other one is called RPact. And I suppose the emphasis is using technology to our benefit and really embracing technology. So there are two pictures of the Space app, Space and RPact. And just in summary, so the COVID-19, I mean, this time a year ago, I'm sure none of you would have realized the changes that you've had to make to practice, and really making us question why we do what we do. You fall into a routine and you just get used to it. But it's allowed us to take a step back and refine processes and really question why are we doing what we're doing. And the focus then on engaging with patients over various lockdowns and the impact of screens, and just like a huge change and shift in patient sentiment and how we've adapted to it. And I would absolutely love to hear your experiences as well, and hopefully we can share some ideas on how you've adapted to things also. So listen, thank you very much for your attention, and listen, we'll start. If anyone has any questions, be more than happy to answer anyone.
Okay, all right. I think thank you so much for that wonderful presentation. I think sharing the experience across is the only way, I guess, to learn from what people are doing around, and what we can incorporate and share ideas across. And I think the couple of softwares which you talked about, which can help us monitor our patients, what's happening on with them, it's really important in these days, right?
Yeah, I mean, I think it's surprising when you talk to somebody, say for instance, someone coming in for a myopia management assessment, and then you start talking to them about their, how much time do you spend playing PlayStation? How much time do you spend reading? Do you use your tablet, or do you play Xbox more? And it varies when you ask the child. I'll always ask the child, and then you turn around and you ask the parent, and there's a huge mismatch between what they say. You say, you can't call anybody a liar. you find yourself in trouble there. But that's why we say I used to use the iPhone and the screen time
Yeah.
report. I used to use that, but then since the VIVIOR device came along, there's patients and parents are completely blown away by, oh my God, do I spend that much time on a device? Or wow, I didn't realize I wasn't getting outside. I thought I was out way more on a day-to-day basis. And then when you introduce it to the young myopic child, the parents come back and they say, I want to use that device. I want to get an idea of how long I'm spending on my screen. And
Yeah.
I want to, it piques their interest as well. And then when you can run them through the report and show that actually, you know what, at the weekend, you're better off using, say, doing a mini monovision with contact lenses. During the week, you're much better with this type of occupational varifocal lens. You're really tailoring solutions to the patient. They feel more invested in their solutions, and it differentiates you in terms of the care that you're providing, that you're really listening to the patient, and you're really answering their needs.
That's right. Okay. So let's take up some questions. And yeah, this is regarding your device. How long does the patient keep it? And if you would like to mention about the charges of it, I mean, do you bundle up as myopia management, or is it sold separately? Or if you could.
So we advise the patients to wear it over the course of about maybe 5 days, thereabouts. And we would advise them to, depending on the patient, but we'd tend to ask them to do it, say, on during their normal week, but also to wear it at the weekends during their leisure time. So you get a little bit of a taste of both scenarios, because we know that patients do different things when they're enjoying downtime with their family, or out playing sports or whatever it is, versus what they're like during the week, whether they're school or work. We charge €100 for the device that they wear, and then they return it. To us, and we give them their report then. So we do have it as a separate cost. We recommend that they do it, because I suppose, from a business point of view, the uptick in terms of actually potentially selling 2 pairs of progressive glasses, getting them into a contact lens solution. So we would recommend that they use it, but not everybody takes it up. So we're not going to say just because they haven't taken it up that we can't offer a treatment, but
That's right. That's right. I think it will be kind of a useful tool for a clinician, rather than, and it's, as you said, it's much more beneficial when we counsel our parents, the patients, as well as the parents, that, we have an evidence saying that this is what you did across the 5 days you wore, right? So it's more of a easy way to talk and explain to the patients, rather than kind of full management. It's not going to help the patient in that sense, but it's going to help us as clinician to explain, right?
100%. I mean, it's so easy when you have all the data in front of you, and you can just talk the patient through this, and this, and it's easy for them to understand. And that's why it's such a powerful tool.
That's right. Great. And let's look at another question. In your experience, if you would put it that way, what amount of, or what percentage of variations have you seen in refractive changes before and after pandemic due to dry eye? So was there any relation to that? And how often do you call them for dry eye management follow-ups?
So the percentage of variation, I would say you're probably looking at about maybe 60 to 70% that we've noticed refractive shifts. before and after the pandemic. But even when it comes to a dry eye patient that's, say, considering surgery, we'll send them off for a minimum of 8 to 12 weeks before we get them back and measure again. I'm not sure if this study has been published yet or not, but they looked at just using a lubrication drop to deal with SPK stain. And they noticed that it took 45 days of just using a lubrication drop 4 times a day to notice improvement in the ocular surface. So that gives you an idea of the timeline. And I think it was 120 days before it had completely resolved with lubrication drops only in terms of the stain. So it's a huge time frame. So we recommend 8 to 12 weeks. We'll get them back. And like I said, 60-70% of patients, you'll notice a change in their prescription. When I'm refracting a patient, you usually get a good idea if they're dry or not. If you're doing, say, checking their astigmatism and you're going around in circles, going around and around, and you're not getting a definitive endpoint, I'll know before I even look at them at the slit lamp that they have some sort of ocular surface issue. So yeah, it's such an important part of my day. I would say 80% of people that come into the clinic, I spend time talking about managing dryness. So yeah, it's a great question.
Yeah, and I think it's really important in your practice as well, because as you mentioned earlier that your practice has the refractive, surgical procedures, the LASIK and the refractive lasers and all that. So if you are not getting a accurate refraction and all that, it will definitely affect and the outcomes of the result, and you do not want to that to happen.
Exactly, and you'll be the one that's blamed for a poor outcome when your fault will be the fact that you didn't address the dryness. But if you can, back to the slides that I showed about measuring, say, the 5 diopters of SIL, if you have a very poor ocular surface and you put a trifocal IOL into a patient who has, say, a tear breakup time of, I don't know, maybe 2-3 seconds, the optics in a trifocal IOL are already massively complex. You put a poor ocular surface on top of that, and you're going to end up with a really, really unhappy patient, and they'll be fingering you for the blame.
That's right. Yeah. So it's very important because as optometrists, even if you are involved in refractive surgeries or not, I mean, you will be doing the refraction part of it, and the refracting surgeon is gonna take that numbers, place it in your refractive paper as the goal mark. You cannot be doing wrong.
Absolutely. But even within an optometrist practice, if you're going to fit somebody in contact lenses and they have meibomian gland disease, they're not going to get on well with their lenses. They're going to report dropout, intolerance, comfort issues. For the presbyopes, it's vision, not comfort, as the main reason for dropout. And again, we know the complexity of a progressive contact lens, and couple that with a poor ocular surface, you're going to run into issues.
That's right. Great. And the next question here is, any experience if you probably had in using this VIVIOR device for low vision patients to check for their visual behaviors and ergonomical visual statuses?
Yeah, I mean, listen, we don't specialize in low vision, but as I said, Lanish, you're already thinking outside the box, but absolutely you could use it for visual ergonomics. That's what it's there for, and that's a fantastic idea of using it for low vision patients. I never actually even really thought of that. Yeah, it's perfect objective data, and that's a great idea.
Great idea. Yeah, I mean, we can definitely try because it's monitoring, so of course it will help us in some way.
Right? Absolutely.
Okay, let's look at another question. Just as per your experience, this thing, who will have more dry eye problems? Is it normal patient or patient who is wearing glasses, or contact lens wearers would be more prone or susceptible to dry eye, considering the pandemic situation? So,
Yeah, so I would say naturally it will be the contact lens wearers. Contact lens wear can affect the morphology of the meibomian glands. Contact lens where your average contact lens is probably about 70 microns thick. We saw that the tear film is only about 7 microns thick. And what happens when you wear a contact lens is you cut the tear layer in two. So you split it into a pre-lens tear film and the post-lens tear film. So because it's thinner, you can run into issues with increased rates of evaporation. So for the contact lens patients, that would be an issue. But again, if you manage the ocular surface well before suggesting contact lens wear or making sure that they're match fit for lens wear, you're going to save yourself an awful lot of time. And you're setting patients up for success, as opposed to, I didn't get on well with those contact lenses, and eventually they'll end up blaming you. But if you spend the time initially, it'll be definitely for your benefit.
great. And let's look at another question. Any specific cutouts on the magnitude of refractive error to consider customized optical solutions? So do you take refractive error as probably more than 6 diopters would not be suitable or something like that?
No, so that's a very interesting question, and there's no simple answer to it. So it is done on a case by case basis. So we have something called an EX500, and that's our excimer laser, and it's made by Alcon, and it'll treat up to -12 diopters of myopia, -6 diopters of astigmatism, and up to 6 diopters of hyperopia. But we know that if it depends on the patient's K values. So if they have a particularly steep cornea and they are undergoing a hyperopic treatment, you know that you're going to be making the cornea steeper again. And there's a limit of probably about 50 diopters as to how steep you can make a cornea. And on the other side of things, if they have a very flat cornea and you're going to be doing a myopic treatment, there's a limit to a cutoff of maybe about 34, 35 diopters in terms of the flatness of the cornea. The other issue then is corneal thickness. So if you have a particularly thin cornea, you're going to be removing tissue, and there's a limit to how much tissue you can safely remove. The cutoffs that we use for LASIK is we like to have a residual stromal thickness of 320 microns. Sorry, for LASIK is 300, and then for PRK it's 320. But then the really high prescriptions, so say you're -14, you're -15, and they're a young patient, that's when we'll start suggesting the implantable contact lens or the implantable Collamer lens. And those patients are often the happiest patients. They've probably been to a good few places and they were told, no, you're not a candidate for laser, and then you come up with this solution, and they're delighted just to be offered something different. But yeah, listen, Deepak, the answer is case by case basis, and there's a lot of information that you have to consider before you can suggest a treatment.
That's right. Yeah, very well put in. I think it's a multifactorial thing. You need to look at refraction, K values, corneal thickness. It's not just looking at refractive error alone, right?
Exactly.
Okay, a couple of more questions here. So we do understand that mask-induced dry eye is something which is there now. If patient walks in wearing a mask, which is but natural going to happen these days, what is any alternative? What is the alternative to this? Because we do understand that mask probably has induced dry eye. Do you recommend them to take off their mask or would you just proceed with that? Any thoughts on this particular aspect?
So what we've been doing is when they come into the clinic, they have to take off their own mask and they have to put on a mask that we provide. It's a surgical mask. So it actually fits really well over the bridge of the nose. So we get them to fit that really well over the bridge of the nose. And we actually have the bottom of the mask comes out a little bit so that the air is actually expelled downwards. Now, don't get me wrong, there's a lot of times with, say, patients wearing those masks and you have them behind the phoropter steams up, you're cleaning the phoropter head, you're cleaning trial frames. So it's a huge issue and no, I suppose, simple answer to it. We don't recommend that they remove their mask during the consultation from a safety point of view. Perhaps in the future, when we've all been vaccinated, and then it might be a little bit more acceptable to remove the mask. But ultimately, you'll get a good sense of things yourself during your refraction, whether they're giving consistent responses. If they're not giving consistent responses, if there's a poor endpoint, then you're paying particular attention to the ocular surface. Then when you're doing the examination, obviously you'd be looking for things like, say, cataracts or any issues with the posterior segment. But if you notice that there's something wrong with the ocular surface, then we'll revert back to our, say, 8 to 12 weeks of treating that, and then they'll come back to the clinic.
Great. So yeah, removing the mask is again something which is, at this point of time, as you correctly said, is something which we do not want to probably advise.
Yeah.
And I think you put a very good point, is the mask is not the cause. I think is the fitting of the mask which is probably causing the dryness and all that. So make sure the mask is fitting well, and I think if that happens is great, right?
Yeah, we do notice a huge difference. Yeah, I mean, even like from a personal point of view, I've definitely noticed an increase in my own dry eye symptoms from wearing a mask. I was wearing a pretty poorly fitted mask, and then we changed over to to the surgical mask, much better fitting, and almost instantly I noticed a decrease in symptoms.
That's right. Okay. And any differences you probably have noticed with people using different types of the screens, LCDs versus the newest one, the AMOLED type devices? So any differences that when they use these different types of screens, their dryness or symptomatics is different? Any thoughts on that?
It's a very interesting question. I personally haven't noticed any difference in it, but I haven't been asking the question what, whether they have an LCD screen or if it's a newer type, an OLED or something like that. I actually haven't been asking the question, in all fairness, but that's actually that's a very interesting thought, and something that could probably be looked into further if there is an association with the different type of screen having a different impact on the levels of dryness. So not something that we have looked at ourselves. It's not a question I've been asking, but a very interesting one.
Yeah, I think probably that should be maybe one of the history questions now we should ask, or maybe look at the evidence, if there is any evidence saying that these things happen, and maybe we can add on this history question and ask our patient what type of digital device are they using, and maybe try to relate it in the future, right?
Yeah, I suppose, does the different type of screen have any impact on the blink rate? Because essentially it comes down to the blink rate.
That's right.
And does an LCD screen reduce blink rate more than an OLED or AMOLED, as you suggested? And I think that would be the question.
That's right. Great. And let's just take one last question. So sleeping pattern, again, this is something which is kind of debatable, and people have talked about it a lot. And the person says that many of the dry eye patients are also not sleeping well too. Do you think that sleep quality causes the dry eye problems to aggravate, or any thoughts on that?
Absolutely, 100%. Sleeping position as well. If one of the most common tests that I'll do on patients is lid closure. So if you have a transilluminator or even a flashlight, you get them to close their eyes and you put it just on the lid, and you'll see if there's any light escaping. Then you know that they would be an incomplete blinker. They might be those patients that would say sleep with their eyes ever so slightly open, and they end up with that smile staining on their cornea. A lot of patients, I'd say, how do you sleep? They say they might sleep on their side like this. They might sleep on their hands. And sleeping on their hands is actually a very important question when it comes to keratoconus. We've a huge, we notice a huge amount of people who report, say, sleeping on their hands, and you'll notice that their topography would show inclinations towards, say, form-produced keratoconus. So absolutely, sleep quality. If you get shift workers, they often report obviously quite erratic sleep patterns. They might be working nights one week and days the next week. You'll find so much, or you find an increased incidence of dryness among those patients as well. So yeah, absolutely. How, if they're not sleeping well, and then their sleeping position, sleeping patterns will definitely have an effect on dryness.
That's right. Yeah, great. So I think with that, thank you so much for that wonderful presentation, and also, sharing your thoughts and answering the question. Thank you so much.
Yeah, listen, it was my pleasure. Thanks to everybody who's given up their Sunday evening to listen in. But if anybody ever wants to get in contact, Fakruddin, you can share my email with them. But yeah, listen, thanks very much, and all the best. Hope you enjoy the rest of your Sunday.
Thank you so much. I do understand it's afternoon for you. It's a family day. But
yeah, the sun is shining, which is a rare thing in Ireland. So we're going to go out and enjoy some sun.
Great. Hope you enjoy your Sunday evening. Thank you so much once again. And I can see the chat also filling up with the thank yous so much.
I'm much obliged. Thanks very much.
We do have session planned next weekend. So until then, take care, be safe, and I hope to see you next weekend. Bye-bye.